Sickle cell disease and the lung. Etiology. Patients with sickle cell anemia frequently develop acute pulmonary complications of their illness. The major pulmonary problems that occur in sickle cell disease include asthma, infection, thromboembolism, acute chest syndrome, chronic pulmonary fibrosis and pulmonary hypertension. Epidemiology. Acute and chronic pulmonary complications of sickle cell anemia are common but often underappreciated by healthcare providers. These conditions have clearly emerged as major threats to the well-being and longevity of patients with sickle cell disease, with more than 20% of adult patients likely to have fatal pulmonary complications of sickle cell anemia. Acute chest syndrome is the most common cause of death and the second most common cause of hospitalization of adults with sickle cell anemia. Mortality rates for children with sickle cell anemia have declined because of penicillin prophylaxis, vaccination for Haemophilus influenza and Streptococcus pneumoniae, widespread implementation of newborn screening programs for early detection, and improvements in parental education. Despite significant improvements in the life expectancy of patients with sickle cell disease, the median age at death is 42 years for men and 48 years for women. Clinical presentation. Any patient with sickle cell disease presenting with fever, pleuritic chest pain and shortness of breath should be carefully assessed and admitted for observation. NB. Aggression and/or confusion should not be mistaken for a psychotic or drugged-up individual. The patient may well be hypoxic and septic. The acute chest syndrome is defined as a new pulmonary infiltrate on a CXR accompanied by fever, chest pain, and a variety of respiratory symptoms including coughing, wheezing and tachypnea. Acute chest syndrome often develops after vaso-occlusive crisis. Multiple factors may contribute to the respiratory distress associated with the acute chest syndrome, including infection, pulmonary fat embolism, iatrogenic fluid overload, hypoxemia, atelectasis secondary to splinting from painful rib and sternal infarctions, and pulmonary vascular obstruction. Physical signs. Fever, confusion, dyspnea, crackles in lung fields and evidence of consolidation. Investigations. Emergency. For acutely ill patients obtain the following. FBC, severe anemia may require transfusion or exchange transfusion. Urea and electrolytes, ensure the patient is not dehydrated. CXR, look for pulmonary shadowing, consolidation and opacities, Fig 27. Arterial blood gases, look for hypoxia. Acidosis is a marker of severity of the illness. ECG, check for signs of acute or chronic right heart strain. Short term. Aimed at identifying reversible disease. Ventilation, perfusion scan or spiral CT looking for emboli and infarction. Sputum for microscopy, sensitivity, and culture. Echocardiographic assessment of pulmonary hypertension. Long-term. Lung function tests. Note that sickle cell patients often have reduced indices even when in relatively good health. Most patients with sickle cell anemia develop abnormal pulmonary function characterized by airway obstruction, restrictive lung disease, reduced gas transfer and hypoxemia. Treatment. Emergency. Try to reassure the patient while administering broad-spectrum intravenous antibiotics and fluids. High-flow oxygen, humidified if possible. Adequate analgesia. Anticoagulants as for pulmonary emboli if veno-occlusion is suspected. NB. Hypoxia in sickle cell disease is often ascribed to co-administration of analgesics and/or sedatives. This could be a dangerous assumption, and you can check it by measuring PaCO2. Reduction of respiratory drive should not affect the arterial, alveolar gradient. Short to long term. Close cooperation between hematologist and respiratory physician is helpful. Prophylactic antibiotics will help reduce episodes of infection. The patient may require lifelong anticoagulation. Complications. Repeated pulmonary emboli and infarction may lead to pulmonary hypertension, cor pulmonale, and right heart failure in relatively young patients.